Good morning, everybody. It's a great pleasure to invite the distinguished panelists here to this very interesting panel discussion. Let's see how it goes. We have people on the panel with diverse backgrounds, interests, and expertise in cancer prevention and screening strategies. And to my left, I have my half-brother, Dr. Chintamani, who will be co-moderating with me and also participate. What I thought I would do is initially we would go around the panel and ask each one of the panelists to tell briefly, maybe less than a minute, about their background and their interest in either prevention or screening strategies. And then that will give me an opportunity to ask further questions. Can we start with Dr. Shirali from here?
I'm Rashmi Shirali. I am a clinician, physician. I spent a lot of time in oncology doing clinical research, got interested in public health, and that's how I done my master's in public health. So I'd like to really address the issue of the space which is common between oncology, clinical research, and public health.
Good afternoon. I'm Dr. Gaurav Mishra. I'm consultant at the Department of Preventive Oncology at Tata Memorial Hospital. And I'm involved in cancer prevention and cancer screening since the last 12 years. My interest lies in the early detection of breast, uterine, cervix, and oral cavity cancers. And I'm interested in research as well as the clinical aspect, both clinic-based screening as well as community-based screening.
Hello, I am Dr. Andrew Benson. I am Scientist C at National Institute of Pathology, ICMR. I am a pathologist, but I am also working in molecular biology, looking for biomarkers for early detection, prevention, and treatment modalities for chemotherapy treatments in breast cancer and prostate cancer mainly.
I am Dr. G.K. Rath. I am working in AIMS for about 40 years now. I am the chief of the cancer center at the AIMS, and I am associated with a program of the Government of India called NPCDCS. We can discuss if somebody wants.
Good afternoon. I am Dr. Vijayalakshmi. I am from Cancer Institute, Chennai. I am a molecular biologist and I was working for Department of Molecular Oncology, but now currently I am Department of Preventive Oncology, where we are doing a community-based screening for cervical cancer, breast cancer, and oral cancers.
I'm Shiv Srivastava. I'm co-director of the Center for Prostate Disease Research at the Uniformed Services University in Bethesda, Maryland. I'm a cancer biologist also, and I'm working in prostate cancer field, so I can't escape the screening issues. So that's why I'm here. Thank
you. Great. Dr. Srivastava has got a couple of slides to show. Once we show the slides, I think we'll start questions from there. Can we have the slides for Dr. Srivastava, please?
Yeah, so when I saw my name on this panel, I didn't know what I was doing actually, and so I started thinking this morning, not to disappoint Dr. Kovali here. So I'm looking at the American Cancer Society, statistics. When you kind of pay attention to this, there's a significant decrease in the death rate among all cancers for men and women, showing here from 1991 to 2008. And I think what's quite striking here is when you look at the trends, basically there is a very significant decrease. And at least, the way I thought about it, a lot of it is due to early detection and perhaps, maybe for prevention. So the way I was going to address this discussion here was lessons learned. And so obviously, I don't have to pre-share that screening is good, but I think the way the question was raised on the, at least in the program, if I could just have the next slide, please. So I kind of, just gave my naive input here. So apply the lessons learned from the cancers, which have been already in the forefront of either screening or a lot of prevention strategies. Yes, we should screen and prevent, as in most screening contexts, cancers have been caught earlier and better managed. Prevention, of course, you heard about the previous talk, outstanding lecture by Dr. Anurag Srivastava, and I think, in the context of lung cancer, smoking, at least in US, it has been a dramatic, say, observations. I can just go to the next one. So my personal experience in prostate cancer, PSA did revolutionize the early detection of prostate cancer. Localized cancer is treated effectively. Clearly, there's an overtreatment issue which has come up because we're detecting early. And, but in my mind, at least, we certainly do not want to go back 20 years when a large proportion of patients suffered from incurable and metastatic disease. So that's something, I wanted to bring up here because people say, why screen for, say, prostate cancer? If it's not doing anything. It was doing a lot of suffering to patients, at least in the US population, I can tell. And in India, we're detecting very high % of patients in metastatic, say, cohort. So I close by the last slide, just one more there. So clearly, the screening did help, but I think it has brought another, say, set of issues, which will happen to most of the cancers detected early. Not only in prostate, I'm hearing in breast as well as in, in lung cancer also. Multi-day clinics, which Dr. Gopinath presented, I think could be a way that careful, say treatment strategies using the risk stratification, processes, in place that not treat everyone, and have careful, risk stratification. I think from a molecular biology perspective, why PSA failed actually is because it's not cancer specific. So I think, if we were developing a test today, PSA will never make it to the, in the forefront. So that's what I'll say, that the more precise markers will help. Simpler markers like, say, observational or good imaging technologies. And then, of course, the better prognostic markers. If we are detecting early, we have to have that. Because we got to differentiate between indolent from aggressive cancer. So I think I'll stop there. Thank you.
Well, thank you very much for that overview. You gave a background to whether we need screening in the first place at all, and if we do we need a more sensitive and specific modality to reach to a conclusion. And good that you brought out the flip side to it, so that we can look at both aspects. So, so we can start with Professor Rath, who's actually a pioneer of everything that happens in the country regarding oncology. So, what are your views about screening, sir, in the first place? Do you think? I mean, to say that it's not required is also a wrong statement, but at the same time, are we really justified in putting it as we see it happening in the West in an Indian scenario?
I think it's justified, but it's not practicable in a population of 1.3 billion, where we're adding one Australia every year. Australian population every year, 23 million added every year. It's practically impossible in our lifetime, maybe possible in our grandson's lifetime. It is needed, to answer your question. It's needed, but it's not possible.
So there are studies there are trials to show, including the Canadian trial, but many a times we overdo the screening part. I mean, while you're right that the era before screening and the era after, the survival rates did improve, but it also coincided with better modalities of treatment coming into. So single out screening being the only factor contributing to better survival after screening started would be also putting it at a very higher pedestal.
Right. That's not the only thing. Other things should also.
No, the question was whether it is required. Feasibility is the part 2 of the problem. Whether you can do it at all. The question is whether we need to do it at all is the question. Whether we, your point is well taken that we need it, but with some kind of a filter, we need to understand that. Dr.
Maybe for example, like as I showed, as I discussed yesterday, the highest incidence of cancer in our country is Mizoram. And I'm sure in that population, where the incidence is 243 per 100,000, the screening is required for esophagus and gastric cancers. There it's required. Opportunistic screening, not all over the country, but in certain population where it's high, like, for example, it's a gallbladder cancer, is the third commonest in Delhi. So probably some sort of screening is required, but this is not the only thing. We should have other things also.
Thank you, sir. Dr. Gauri, would you like to add on to that, please?
Yeah, Yeah. I believe that screening is truly required in our country, and we cannot question it when we bear 1/3 of the global burden of cervix cancer cases, 1/4 of the global burden, and 1/3 of the global burden of oral cavity cancer cases. A single country bearing this. We do need screening definitely, but we'll need to devise our own strategies which will be suitable to our kind of population. We cannot apply the tests that have been investigated in Western countries which are suited more for their population. So we need to investigate.
Right, you got a point. We need to find Indian solutions to Indian problems rather than putting the Western way of doing screening here. But screening is required, as Dr. Rath also brought out. He brought out another issue. Economically, it's not viable. So if you're not going to do it, why are we talking about it in the first place? But at the same time, you can't take away from, I mean, it will be bad science to say that we don't need it at all. It makes, it's common sense that we must be able to detect cancers early so that we can give an effective treatment, and that should make a difference. But we need to design our own methods of screening which suit, as you mentioned, organ-specific screening and also population-specific screening, and what is cost-effective and bearable. Any of the panelists would like to add on to that? Dr. Vijayalakshmi.
I think I would agree with Dr. Gauri. There are methods which are very much suitable for a low resource setting like ours, and people have tried it out extensively, like your visual inspection with acetic acid as far as cervical cancer goes. So that way VR test has been found to be very sensitive in picking up the lesions, but the problem we have with VR is its low specificity. So that is why we have the other tests like VR, villi, with HP, high risk HPV and cytology based. These are the different tests which have been used to screen to pick up the precancerous lesions. And I think VR along with HPV, like we have a program which is ongoing in Adyar Cancer Institute. What we find is if we do the VR and HPV parallelly done, then we can actually come up with a better sensitivity and specificity to pick up the precancerous lesions from the community.
So it's possible to develop our own solutions, but what you're saying is that you need technological changes or advancement or what is preventing you from developing your own?
I think so, sir, because as far as VR is concerned, it is, not so expensive to do. But the high-risk HPV testing that we are currently followed, the FDA-approved methods which we are following are definitely expensive. So that way, I think we would need more technologies to come up with cost-effective and cheaper HPV detection assays, which will be suitable for our community, which we can do it easily here.
Okay, so I wanted to tie up the screening and prevention together for a minute. Based on what I heard from Dr. Gauravi and Dr. Ra, it's needed, but its population is too large, it's difficult to do it. Therefore, on one side we have deficiencies in the technology. On the other side, we have the enormity of the population itself, the number of people to be screened. Can we club screening and prevention strategies together? For example, Dr. Rod was mentioning in Mizoram, we know the areas where the genesis of the disease is coming from lifestyle. So why not we focus on prevention strategies and screening strategies? Dr. Rod, do you have thoughts on that?
Prevention, early detection, and management almost go hand in hand. Otherwise, many times when we have concentrated on prevention and screening and there is no treatment, the whole thing bounces back. Where do this patient go? And the whole program bounces back. So that is the problem. For example, if you say the need for the various facility of treatment, today we have at any time, for example, our incidence of cancer is 10.8 lakhs per year. We have facility for about 1/3 only. 2/3 of the cancers are not treated. They simply die without treatment. So unless we have both the things simultaneously, the whole program will not work.
Excellent point, sir. And at the same time, sometimes screening may over-detect and may detect cancers that are actually not there, or may detect in situ cancers which will never become invasive in the lifetime of an individual, and you end up spending a lot of money on that and also end up giving some anxiety to the patient. She or he lives with a ticking time bomb inside. So it has a flip side which also should be taken into consideration. And as Professor Rath brought out, you got to provide both at the same time. You can't leave them after screening. So you naturally need to have, like when they started with the fecal record blood kind of a thing in the US, that it had to be followed up with colonoscopy. So the cost were added up. So the many negative colonoscopies made it almost not cost effective. So your views on that, Dr. Rashmi, would you like to add on? I mean, you can use that mic.
Actually, I thought that prevention and screening, we are using common strategies, but we need to understand that prevention is a larger umbrella under which screening is one of the tools. So when we talk about prevention, we are talking about many other things. In fact, Dr. Srivastava's study, which he presented just now, was quite a revelation for me, that despite all the processes that they conducted as part of the study, the transformation to cancers was very limited, and the previous studies have shown very different data. So he says that the reason was that they gave a lot of knowledge, information, etc., via the leaflets, brochures, and information that was provided. Do we conclude that there are other non-technological tools by which we can have effective control? And if so, then we should address our efforts in that direction more than maybe the strictly technology-oriented, high-cost, tools by which we are addressing screening.
Yes, so I'd like to make a comment on that. I think excellent points. The point here is that Dr. Rath keeps telling yesterday and today that we are adding more population, more cancer patients are coming up. So on one side we are screening, and then we heard all the comments. On one side we are screening and detecting, on the other side we are adding more people by not controlling the lifestyle that is promoting the cancer. So how do we develop strategies that while reducing the incidence of cancer in future generations and treating by screening the patients in the current generation or target population in the current generation, so that we have in the next 20 to 30, 40, 50 years, we have a net of 0 incidence of cancer. Dr. Rath, you take on that.
My views are very simple, and I think that's what I have been teaching my students. Till the time we have a strategy for the country, we cannot sleep. We have to work. And all of us sitting here can do the same thing, and we have been doing that. We have to first get convinced that prevention works. And I tell some example to people who don't understand too much, is that, for example, in our country, there is a proof that tobacco causes cancer. In Punjab, state of Punjab, where 51% are Sikhs, they do not chew tobacco. They do not smoke. I'm sorry, with all respect to Dr. Ravinder. So the proof is in our country. You don't have to go to Washington, New York, London to learn that tobacco causes cancer. It's in our country. So we are convinced that tobacco causes cancer. So who will teach them? I mean, the ministers are not going to, we are going to teach them. So what we do is, we have periodic camps to teach people that tobacco is bad. Proof is here. For that, I do not think that, there is any strategy. There are strategies in the country, like under NPCDCS, but most, of these schemes are not going forward because there are no takers. For example, who will do this? Somebody has to do this. Somebody with cancer knowledge has to do this. So all of us, if we say, for example, say teach, do some camps, teach people in a group, systematically, whatever way, this has worked, and that's my personal feeling. That's the only thing which will work, unless we are convinced. 30% cancers are tobacco related, 20% infection, and 10% lifestyle. 60% cancers are preventable, and we have proof for all of them. If we are not convinced, how can we convince others?
Excellent point. Everyone knows that. Everything literally. That's a good point. We don't explain awareness. Okay, let's go to the audience. We have some discussion here. So Dr. Raj's point is that we know the cause, we don't prevent it because we don't have a policy. So the blame goes directly to the government, obviously, here, because tobacco, for example, we're talking about it. Tobacco is not a green leaf. It's not a brown leaf. It's a green currency, basically. Therefore, the government lives on tobacco consumption, basically, indirectly speaking. Hold on a minute, until you get a mic, please. If we stand, if we could stand for the. Hold on. Okay, sure.
No, didn't get your point. I mean, you have what? So problem is the accumulation of data. What he's probably referring to is, are we doing enough to kind of initiate these programs? His question is, I mean, anybody's business is nobody's business. So actually, nobody really knows. Sensitizing politicians is a big deal. I think you look at, you're talking about refractory cases, no? Politicians don't get sensitized. Dr. Anju, would you like to make a point in that direction? Because she's a molecular biologist who's involved in many of these projects that we do. Yes.
In India, 80% of the cancers that we detect are in stage 3 and stage 4, and at that time, very few treatment options are available, and they lead to a lot of morbidity and mortality. So early detection, no doubt, is very much needed in our country, and breast cancer is one cancer which is coming up due to unknown causes, one of which is westernization of the lifestyle. That is what is implicated. And we do not have even breast health care programs, awareness programs, which is very easy to, we can advertise on the radio or on the television for the breast health care. And that is one cancer which can be prevented, because there are studies which have shown that clinical breast examination and has shown results in Trivandrum and Cairo. And also I think the breast self-examination will show results. So that is one cancer, I think, which needs no, it doesn't need any money. It is done in privacy, and a woman should be aware of her breast appearance, and any change noted should be immediately reported to the healthcare provider.
Okay. So I think we have mixed issues here in play. So what I was asking the audience who may want to comment is that, what do you think the government should do? Because the population here has a direct control on what you can tell the government. For example, how do you tell your own government, say, what you should do? I want to give a chance to that lady, young lady behind, please.
Yes. Shout, shout.
Hold on.
I have been visiting AIMS from last 3 or 4 years, and I have seen patients. I deal there in the renal cell carcinoma department, and I've seen nephrology mainly. And I've seen patients, like many patients, dying because they didn't get the date of operation, they didn't get the date of chemotherapy. So has anybody from the HODs of AIMS, जो कि oncology में काम करते हैं, have they ever reported to the director that this is happening here? There is no special center in AIMS. A place like Rajiv Gandhi, it's not accessible for all. A place like Max, it's not accessible for a poor man in the country. So have they ever reported that there should be a special or a separate center in at least in All India Institute of Medical Sciences for the patients?
Where do you work?
I work in Jamia Hamdard.
What do you do there for? You're a research student?
Yeah, I'm a research.
You kindly introduce yourself when you ask a question. That's one. The second thing is, why are you expecting All India Institute to do it for you?
Because that's the only place that's accessible.
No, the world is full of places where anything can be done. So what do you are you associated with? I'm sure they're doing adequately enough in that direction. But what are you suggesting, that one place should be dedicated to screening? Is that what you're saying?
Yeah, screening. We should not look that this Mizoram is the only place where the breakout has been so high. Why do we wait that there should be breakouts and then we will go to the...
No. They didn't say that they waited for the breakups.
No,
they want just... He was just quoting the data so that we can... Can I just finish? You're just waiting for the... The data collection is what leads to your understanding about which is an area where there's a higher incidence and prevalence. Yeah. Otherwise, how do you decide on screening? Screening is not something you start offhand. It's not. It involves cost. It involves the state, the country, the whole the governance is involved. It's not something which can be done privately. You understand that? Yeah. So at the same time, what Dr. Rath was highlighting was they are doing it. Many centers in the country have to do it. Then the data gets pulled in. And then you actually, screening is not about one center doing it in one clinic, right?
All right.
Thank you.
Our point is well taken. I think we'll
Yes,
get back to that.
the one gentleman in the black shirt.
Hi. Hello.
Okay.
I'm Gaurav Roy. I'm doing my PhD in liver
Level
cancer from
Little
Jamia
level
Millia
end, no?
Islamia.
Yeah.
So I think one of the burning issues that the government should address is liver transplantation for HCC, hepatocellular carcinoma.
Thank you.
I mean,
government should address liver transplant.
Heard anything on hepatocellular carcinoma till now.
Excellent.
So it is a
Your
very
point is well
important
taken.
issue.
Oh, well,
Yes, it has
it's
to
not
be
related
taken
to
into the
screening
government
anyway.
sector
Dr.
so that
Anurag, you
it
wanted
is
to
not
probably
only for
talk
the
about
private
your own
sectors to
study,
do.
right?
Thank you.
Now, the 4 cases that they were asking, I was going to ask you actually, only 4 in that huge number actually in 5 years, and 4 is not a small number. I was just trying to highlight that point. Yes.
So, yeah, myself, Dr. Shaukat, yeah, I'm a research scholar in ICMR. So why we are blaming government? Why don't we push government to, implement strategies like we can push government, being renowned oncologists in our country. Why don't they push through media?
Push, yeah, okay.
Yes, to the government, to ban tobacco, sale of tobacco. And the one more thing I would like to mention here, should we replace the term for prostate cancer? Like, people who, they come to know that there's a trauma for them, that they have a prostate cancer. They never die of prostate cancer when, the PSA level is, so they live up with the trauma that we have a cancer. Should we replace
It's a very valid point. I think we mentioned that because sometimes screening can psychologically harm an individual. There is a study to show that 80% of, they did a study based on autopsies, 80% individuals more than 80 years had cancer prostate, but they didn't die of it. You're right. But that happens to many cancers. Yes, Dr. Anurag Shrivastava.
I propose that we file a public interest litigation to the Supreme Court of India for total ban on cultivation of poisonous crop of tobacco.
Okay.
There is a public interest litigation.
Dr. Rath and all of us sitting here should sign.
Sir, please.
Our Honorable Minister is a geologist. He knows each and everything. As a minister and head of the health department, he should not facilitate the tobacco grower. And full size newspaper advertisement is there.
Thank you, thank you, sir. Thank you.
All right. We got the point here.
In support of the tobacco grower, instead of the strategies they have to adopt as far as the tobacco cancer program is concerned, regarding the strategy.
Just one point there, Dr. Gopala, 1 second. Dr. Anurag, actually ASI and Dr. Ramakant, there is a PIL which is being filed in Supreme Court. You're absolutely right.
Very good.
Against tobacco use, but growing crop is what I think makes more sense.
Talking of growing, because unless the growth of the crop is controlled, no other measures will be totally 100% effective.
Thank you.
People have quitting programs and other educational programs that do not control tobacco to the 100%. And if the government says that they are generating enough revenue through the poisonous crop of tobacco, may I humbly suggest that they should rather go for cocaine and heroin.
They'll generate more funds.
Yeah, they will generate more revenue.
And then they'll sponsor the
with
cricket
greater
matches
margin of
more
profit.
easily.
If you say that I will generate revenue to the exchequer
right,
through cultivating poison, then go for heroin and cocaine.
We got the point here. I think let's keep this.
I would like to make, which is at Tata Hospital. Imagine someone who wants to quit tobacco coming to a tertiary cancer center. Like every state has just one cessation clinic. So we will need to have some cessation clinics which are less stigmatized and which are there in the community, which can be easily approached by the population. So everything has to go hand in hand.
We got the point. I have a request here now for the. I'm very happy that we have a lot of interest from the audience, which I was worried whether we have or not. So let's keep to the point. And if you have a question or a comment, raise your hand. Somebody will come with a microphone because your use can be recorded. Let's not make too long statements. Let's get to the point so the panel can respond to your question. Thank you, Dr. Gauri. Okay, Sharan.
Please.
Dr. Sharan will first comment and then go to you. Please.
been talking about tobacco cessation, awareness, cancer awareness, all these makes a lot of sense. But there is also one more thing which I would like to mention, that primary prevention, wherever it's possible, can be handled. Like, for example, cervical cancer vaccines. When vaccines are available to prevent cervical cancer, can we do something to make our government implement the vaccine program?
All right, I think that's a point we will come back to later on. I think vaccines different bunch. Rajesh.
Yeah, I just very impressed with the kind of excitement that I see on panelists as well as Dr. Srivastava. But I was wondering why betel nut doesn't figure in tobacco, or is it inclusive? Because that's also a huge spectrum.
It's all included in that. No?
So it's because it, per se the odds ratio for betel nut is as high, almost as high.
So what is your suggestion? You want to include
that, see, the betel nut banning of all those pan masalas
should be included. Thank you very much. That's wonderful. Yes.
And one small point I have.
Please make it quick. We're short of time.
The population of India that has been mentioned many years young now. 30 years later, it's going to be much older, and this will be one country with oldest. Largest.
But you'll still get young people, no?
Okay,
you never know.
But
let's not be so pessimistic about it. You'll still have young people. It'll remain a young country. You'll have old people living longer. You're right.
Yes.
So the profile is going to change. It's a dynamic thing. It's going to change. Yes, the gentleman there. Quickly, you can start screaming. Yes, you are.
We are a set of researchers sitting here, and we're talking of screening of cancer. Now, how many of us have actually come up with certain markers which could at least help somewhere? In the Indian situation, we are a mixed ethnicity, and we've got a mixed set of people and a mixed set of cancers as well. So, looking at the screening, do we have a standard set of screening assessment tools or something like that for all sort of cancers?
You mean one for all?
No. For each specific one.
That's how it is world over. Screening is organ specific.
But sir, in our case, we have a mixed ethnicity. And, in my case, I have looked at oral squamous cell carcinoma. Yes. And I found, for example, as we said, 4 cases from leukoplakia transmitted into cancers. I've looked at 104 leukoplakia tumors with a collaborative study from the dental college. And what I found is almost more than 50% have been cured on their own. They don't need a treatment even.
Sorry, cured in?
Cured on their own. I mean, those patients didn't even.
They disappeared. I mean, you mean leukoplakia, and they stopped taking tobacco after that, right?
Now, sir, if we do have a screening program, I mean, what is the basis of the screening? I mean, what do we, what are we leading into?
Screening is essentially to pick up early cancers in asymptomatic individuals, not patients. Okay. So we are talking about people who have nothing. So this is oral self-examination or looking into the oral cavity can help you detect them early. The whole idea is that there is a philosophy behind all this. Get the cancer early, you may probably provide cure. There's a flip side to it. The behavior of tumor still may change. A smaller tumor with a bad behavior can do worse than a larger tumor with a good biological behavior. You're not getting into that. The idea of screening is generally to get the cancer early.
All right. I think I'm hearing two different arguments here. Let me put it together and ask the people from the West. Here it is. Well, on one side, what we're saying is that prevention, education will help, and screening is important for people who are at risk or whatever it is in populations. Okay. So my question here to Dr. Paul, if you can enlighten me personally, is that in the West, all the programs work very well. There's a decline in the users, tobacco users and tobacco growers there. Okay. Whereas here, there is increase in tobacco users and tobacco. So obviously, just by having an advertisement will not help. So Paul, can you tell us what you think will work in the West, what you think we should do in the East to make it happen?
I think someone mentioned that you need a national strategy for cancer, which you don't have.
Correct.
And then the question is, what should so a policy that promotes a strategy that is most effective. Everyone's got their favorite risk factor or their favorite cancer that they want to prevent, and that's all very well and good, but you will always be constrained by limited resources. So what you really need, I think, is an evidence base that tells you how many, for example, for every rupee you invest in whatever cancer, either treatment, prevention, or screening that you do, what it gains you in terms of disability-adjusted life years, okay? That way you'll know how to prioritize the spending of your money to get the most impact for the grouping.
Thank you.
Excellent point. Yeah. So, Shiv, do you want to take on that from your prostate cancer prevention? Then we'll go back to the rest of the panel on that one. So, what worked in the West in reducing the incidence or prevalence of prostate cancer?
Yeah, it's on.
So I think I just want to clarify before answer your question. I mean, screening has a very significant impact in prostate cancer context. We were seeing, as I said, whether one wants to die with the metastatic disease and have a miserable, say, situation, or is detected early, what happened. There are costs to that also, as addressed. If I were to know, whether I have cancer, I would rather know early, so that it's an individual thing. But I think within the context of the data which is out there, the metastatic disease is a very painful disease. And if you're detecting a stage...
Nobody is denying you need to detect cancer early. That's not an issue.
So, I mean, there were some questions from the audience.
That was addressed actually by and large.
In terms of prevention, I think prostate cancer is an extremely good example. If we use, like I think pointed out here on the multi-D clinic, as well as, detect early, follow in a close fashion, perhaps active surveillance group, which is essentially you're watching the patients, not doing anything with them. And then in that context, you could use some preventive strategies there. Yeah. Hormone inhibitors have been used, PCPT trial in the US, actually looked at the inhibitors of the hormone synthesis. There was some controversy along those also, but that was one of the very clear-cut prevention trial was done in prostate cancer. It's a PCPT trial where they use the finasteride as well as some other inhibitors.
Let me tie up with your little bit of background, and somebody was mentioning too. Like you were saying that you better detect it early, and somebody in the audience was telling that if you detect it, it's a pain, you have to live with the pain. Like he was telling to 20 years, 10 years. If the cancer is indolent, you don't have to do anything, you will live long, happily ever after. So the question is that, can we rechristen the word cancer in cases where cancer is indolent or cancer is benign? So let's not call it cancer. You said that you have something different, this may go to cancer later. So anybody from the public health field, from audience, have a comment on renaming the word cancer in cases where it's not harmful, but it's benign? Hyperplasia. Anybody in the audience would like to make a comment on that? From a policy.
Anybody from the panel will do that. Huh?
Can I address that?
Sure.
So this was a question which came up actually. There was a conference at National Cancer Institute in USA, big issue about overdiagnosis and overtreatment. They call the cancer as, benign cancer, but I think, that's a very difficult concept. Pathologists will never agree. If they detect the cancer cells under H&E, you have to call cancer. I think, it's more education. That's what is needed. You cannot reclassify cancer as benign. I guess someone is pathologist here on that panel.
I'm going to ask.
I can address that.
Anju, what do you think?
Yeah.
Switch on the mic, please.
Percentage of prostate cancers that we detect on biopsy, which is taken for a suspicious benign prostatic hyperplasia, they turn out to be malignant, but many of them are indolent and they do not need treatment. But we do not have a follow-up in our population as to how they have fared, but we can take lessons from the US population. And but we generally do the prostatectomy. We do not wait for the active surveillance that is being practiced.
The issue is not addressed, sir. Yes, exactly.
Good, thank you.
Cancer, yes, it cannot be. No, it cannot be talked, or it cannot be called anything else.
No, it's a cancer.
It's
so
a cancer.
Rest is the story you can talk about, but we don't know which cancer is going to do how. So the treatment, you can't deny a patient a treatment. That's exactly the problem.
Prostate cancer is one cancer which shows a very variable behavior as regards the biology.
So does breast, so do other cancers. You're right.
Still we have to call it cancer, whether it is...
That's the question. Now, anyone would like to chip in? Professor Rath, please.
He's okay with cancer word because it makes money out of it.
Yes, sir.
Hi, I'm Anirudh. I'm a research student at Delhi University.
Thank you.
I would just like to know what kind of importance can be given to psychological implications of social economic factors when you're planning your screening strategies. Because the environment plays a lot of role in the susceptibility of a particular victim. If you can
No, you got your question. What do you think about it? How would you feel if somebody tells you got a cancer? God forbid, please don't misunderstand me. And I also tell you that most probably it's not going to be a bad one, but you'll still be affected. There is a huge psychological trauma associated, and there is a problem. So, I mean, the answer lies in the question. The fact that you're asking the question, there is a problem. And if you detect certain cancers, which are, like I mentioned, the in situ cancers or indolent prostatic cancers, which may never would have, I mean, in this age and age of investigations, you pick up incidentallomas. There's a small microcarcinoma in the thyroid, which may never actually become a, invasive big cancer. It's just a baby cancer which doesn't become an adult, but you can't really swear by it. So there is a psychological trauma associated. This is the flip side of screening people, because you will actually pick up people who are not going to die of cancer. They may have cancer. Sure. Finally, quickly.
If I can just complete that, I think I've been misread.
Yes, sir. Shukla.
If I can just go ahead for 1 minute. I think I've been misread. I wasn't talking about the psychological implications of being termed as a cancer patient. I'm talking about psychological implications of an environment of the particular person while devising screening strategies.
Sorry?
I'm talking
the person who is devising the screening...
I'm sorry, no. I'm talking about the taking in the psychological implications of a particular environment that the person is living in while devising screening strategies. Because if a person is susceptible to being...
it'll be so subjective, you'll never be able to screen.
But
one last question, Dr. Shukla, and then we'll have open.
I'm H. Shukla from BHU Banaras. We are all talking like big specialists. And we are talking about detecting cancer in the population. Unless you sensitize the population to come forward, you might just be having many meetings, but nothing will happen. Please take an example of American president election, how Obama sensitized the whole country and won. You sensitize the population. Population of UK women are sensitized for getting screening done. So their now mortality from breast cancer is getting much less. In America also, people are sensitized with prostate cancer. So that is giving dividends. We have not discussed how we are going to sensitize our population. We can sensitize our population by putting just one paragraph of education material in class 3 students, and that should go unchanged up to the BAs or MSc examination. That is the beginning I think we should do. And that is, we should approach the Ministry of Education to do this. And this will have a great impact on our detection rate. Otherwise, people are poor. Those who live in villages don't even see television. They might listen to some Bihari songs on their television, on their radios. They won't listen to these education material. Now, camps are good, but camps, where is the manpower to organize these camps? There is no manpower to organize these camps. I organize my camps in my village.
We got the point, Doctor. In the interest of time.
But they come for taking snacks. They're not interested in getting themselves examined.
So we can give them snacks as well as information,
Yeah,
then it will
but
be
we
good,
should
good enough. That's what you're
sensitize the population.
Yeah.
All right, thank you, the panel.
Hello, sir. I want to say one thing.
Dr. Saini, please. You will have the last word.
Integrate the social and behavioral aspect as well. Through the behavioral, the social wings of the government or every aspect in our society, social as well as behavioral aspect. That's what I mean.
Thank you. You can probably make the last comment. Can you pass on the mic to him, please?
I sincerely feel that as doctors and as specialists and oncologists and urologists, whatever you are, try to have some small biological behavior of the tumor from the day it becomes cancerous to the time the patient dies. Have some sort of standardized average. It may be $1 million or it may be $1,000, but somewhere that it costs so much for the whole treatment right from the day it's detected till that. And if we sensitize our own doctors and then the lay people, I think that will go a long way. For example, we have done in our own hospital in Bangalore a study for a CA prostate, day diagnosed early care. till the patient dies. And if you have to take all the possible treatment, it will probably cost 75 lakh rupees. This is our hospital figures. It's not a 5-star hospital, but this is probably, if you take all the chemotherapy, everything into consideration. If this can be hit upon the average person, that is what he will understand better, rather than just, so I can think of all other cancer specialists getting together for each and every individual organ. Sensitize your doctors, sensitize your patients.
You're absolutely right. Like sensitizing the individuals was a very important point brought out by Professor Shukla. No screening program is going to work unless the individuals want it. So naturally, if they would want only when they know there is a problem, and you got to tell them that there is a problem. So it's a huge task when it comes to doing it, educating the masses, and then getting into business. Because if you don't, then the business, you really can't do it. Dr. Gopal?
Thank you very much for the panelists, for the participation, and all the audience for the participation as well. Let's close the session. Thank you.
Thank you very much. It can go on and on, actually. You can never stop. And we were going to discuss that point, but the time is an issue. Thank you very much.